Welcome. NSG 525. Study Section 1. Renal Failure. Introduction. We will commence our study in this course by analyzing renal failure. We will start by classifying renal failure and identifying its signs and symptoms. We will cap the section with a review of management procedure of this condition. Learning outcomes. When you have studied this section, you should be able to classify renal failure, signs and symptoms of renal failure, management of renal failure. The type of failure is determined by the trend in the serum creatinine. Other factors that may help differentiate acute kidney injury from chronic kidney disease include anemia and the kidney size on sonography. Chronic kidney disease generally leads to anemia and small kidney size. Acute renal failure. This is a reversible clinical syndrome where there is sudden and almost complete loss of kidney function, decreased glomerular filtration rates over a period of hours to days with failure to excrete nitrogenous waste products and to maintain fluid and electrolyte homeostasis. Causes of acute renal failure. Causes of acute renal failure is grouped into three categories. Prerenal causes, hypoperfusion of the kidney, volume depletion resulting from hemorrhage, renal losses, diuretic osmotic diuresis, gastrointestinal losses, vomiting, diarrhea, nasogastric suction, impaired cardiac efficiency resulting from myocardial infarction, heart failure, desrhematias, cardiogenic shock, vasodilation resulting from sepsis, anaphylaxis, antihypertensive medications, and other medications that can cause vasodilation, which reduce blood supply to the kidney. Intrarenal causes. Prolonged ischemia resulting from pregnant nephropathy, occlusion of kidney structure by pigment release from breakdown of blood cells. Myoglobinuria, trauma, crush injuries, burns, hemoglobinuria, transfusion reaction, hemolytic anemia. Nephrotoxic agents such as aminoglycosides, antibiotic, gentamicin, radiopaque, contrast medium, solvent and chemical, ethylene glycol, carbon tetrachloride, arsenic, heavy metals, mercury, lead, non-steroidal anti-inflammatory drugs, angiotensin, converting enzyme inhibitors. Infectious processes such as acute pyelonephritis, acute glomerulonephritis. Post-renal causes. Urinary tract obstruction include calculi, tumors, benign prostatic hypertrophic structures, and blood clots. Phases of acute renal failure. When any of the factors which limit tissue perfusion in the kidney or harm the kidney occur, four clinical phases are observed in patients with acute renal failure. They are initiation, oliguria, diuresis, and recovery. The initial period begins with the initial insult and ends where oliguria develops. The oliguria period is accompanied by an increase in the serum concentration of substances usually excreted by the kidneys: urine, creatinine, uric acid, organic acid, and the intracellular cations potassium and magnesium. This is because of reduced urine production, which situation these substances are retained in the body. The minimum amount of urine needed to rid the body of the normal metabolic waste product is 400 ml. In this phase, Uremic symptoms first appear and life-threatening conditions such as hyperkalemia develop. In some cases, patients may have increased renal function with increasing nitrogen retention, yet actually excrete normal amounts of urine. 21 days or more. This is the non-oliguric form of renal failure and occurs predominantly after exposing the patient to nephrotoxic agents. It may also occur with burns, traumatic injury, and the use of halogenated anesthetic agents. The diuresis period is marked by a gradual increase in urine output, which signals that glomerular filtration has started to recover. Laboratory values stop increasing and eventually decrease. Chronic renal failure. Chronic kidney disease is often called end-stage renal disease, end-stage renal failure, or end-stage kidney disease, and is synonymous with the now outdated terms chronic disease failure or chronic renal failure. It is defined as a progressive, irreversible deterioration in renal function in which the body loses its ability to maintain metabolic, fluid, and electrolyte balance, resulting in uremia. Epidemiology. The prevalence of chronic kidney disease is 1,007 per 1 million population. There are 26 million adults with chronic kidney disease in the US and 500,000 end-stage renal failure on dialysis. The incidence continues to increase in the US. Demographics. Age. Chronic renal disease may occur at any age, although the various underlying causes are themselves more common in specific age groups. Race. In the US, blacks are more commonly affected by chronic renal insufficiency than whites, although it is unclear whether this difference results from genetic or socioeconomic causes. Focal segmental glomerulosclerosis is more common in individuals of African descent. Hypertension and diabetes mellitus type 2 are also overrepresented in black patients. Blacks are also prone to take herbal and unprescribed drugs. Socio-economic status. In the US, patients who are impoverished with less access to healthcare facilities and inadequate financial support are more likely to progress to ESRD than patients with better financial support and insurance. Causes. The three most common causes of chronic kidney disease are diabetes mellitus, hypertension, and glomerulonephritics. Together, this cause approximately 75% of all adult causes. Glomerulonephritis involves a variety of immunological-induced disease which cause inflammation, fibrosis, and destruction of glomeruli with tubular degeneration. Renal vascular disease involves a nephrosclerosis secondary to hypertension, renal artery stenosis, or atherosclerosis. Diabetes mellitus. Diabetes nephropathy involves extensive glomerular and arteriolar impairment. Polycystic kidney disease accounts for 8 to 10% of cases. Progressive enlargement of the cyst compresses functional renal parenchyma, increasing renal insufficiency in this inherited disease. Drug-induced nephropathy. This is caused by some nephrotoxic drugs like aminoglycosides, antibiotics, eczema H2 receptor antagonists, neurosteroidal anti-inflammatory drugs, phenylbutazone, sulfonamides, digoxin, anticonvulsants, etc., and products like herbal medicine containing dichromates, cadmium, and adulterated drugs. Stages of chronic renal disease. Chronic kidney disease is divided into different stages of disease according to GFR and presence of albuminuria. Stage 1. Disease is defined by a normal GFR less than 90 ml per minute per 1.73 meters square and persistent albuminuria. Stage 2 disease is a GFR between 60 to 89 ml per minute, 1.73 meters squared and persistent albuminuria. Stage 3 disease is a GFR between 30 and 59 ml per minute, 1.73 meters squared. Stage 4 disease is a GFR between 15 and 29 ml per minute, stroke 1.73 m2. Stage 5 disease is a GFR of greater than 15 ml per minute per 1.73 meters squared or ESRD. Stages of chronic renal disease according to loss of nephrons. Reduced renal reserve, characterized by loss of 40 to 75% of nephron function. Patient does not usually have symptoms because the remaining nephrons are able to carry out the normal functions of the kidney. Renal insufficiency. 75 to 95% of nephron function is lost. Serum creatinine and blood urea nitrogen level increases. The kidney lost its ability to concentrate urine and anemia, nocturia and urea develops. End-stage renal disease. Loss of over 90% of renal function. Dialysis is indicated. Pathophysiology. Regardless of the cause of the renal failure, the disease progresses through the 3 stages of reduced renal reserve characterized by asymptomatic decrease in renal function, renal insufficiency, and end-stage renal disease. As renal functions decline, the end products of protein metabolism, such as nitrogen, phosphorus, etc., which are normally excreted in urine, accumulates in the blood. Uremia develops and adversely affects all the systems of the body. A rise in serum phosphate level is seen due to decrease in glomerular filtration of phosphorus. Hyperphosphatemia causes a decrease in calcium level, which stimulates the overproduction of parathyroid hormones and remove calcium from the bone, leading to osteomalacia. Heart failure, pulmonary edema due to fluid overload, and pericarditis due to irritation of the pericardial lining by uremic toxins. Cardiovascular complications are major cause of death in ESRD. The irritation of tissues by the accumulated uric causes GI symptoms like anorexia, nausea, vomiting, and coughs. Neurological symptoms include altered level of consciousness, inability to concentrate, muscle twitching, seizures, and switching. Anemia occurs due to deficiency of erythropoietin, which should normally be secreted by the kidney. Other causes of anemia in CRD include malabsorption of iron from the GIT, shortened lifespan of red blood cells, and the uremic patient's tendency to bleed. Skin changes include pruritus, which occurs due to calcium and phosphate imbalance, loss of libido, impotence, and amenorrhea, and are possible problems of the patient. The reason for these symptoms is not clearly understood. Diagnosis. CRF is diagnosed when renal disease has lasted for 3 months and above. Increased level of blood urea nitrogen, creatinine, uric acid, potassium, sodium, and magnesium on estimation. Blood gas analysis may reveal acidosis with a slightly lowered blood pH and a lowered carbon dioxide level. Reduced red blood cells count level. Clearance test reveals decrease in glomerular filtration rate. Renogram intravenous injection of radioactive substance followed by recording of rate of uptake and excretion rate. Intravenous plyrogram 24-hour urine volume to determine whether the kidneys are producing the 500 ml minimal urine volume necessary for the daily excretion of nitrogenous waste. 2. Signs and symptoms of renal failure. Neurological symptoms: weakness, fatigue, confusion, inability to concentrate, disorientation, tremors, seizures, restlessness of the legs, burning of the soles of the feet, behavioral changes. Integumentary: gray brown skin color, dry, flaky skin, pruritus, ecchymosis, purpura, thin, brittle nail, coarse tiny hair. Gastrointestinal system: ammonia, odor of breath, uremic factor, metallic taste, mouth ulcerations and bleeding, anorexia, nausea and vomiting, hiccups, constipation and diarrhea, GIT, bleeding. Hematologic: anemia, thrombocytopenia, musculoskeletal, muscle cramps, loss of muscle strength, renal osteodystrophy, bone pains, bone fractures and foot drop. Reproductive: amenorrhea, testicular atrophy, infertility and decreased libido. 3. Management of kidney failure. This will be looked at under medical and nursing, dialysis and surgical kidney transplants. Medical management. The main aim of management is to maintain the kidney function and maintain homeostasis for as long as possible. Drugs include antacid, antihypertensive and cardiovascular agents, anti-seizure agents, erythropoietin, and diuretics. Nursing care. Admission: admit patients into a well-made bed. Nurse patients in the well-ventilated quiet part of the medical ward or an intensive care unit of the hospital. Position: place patients on any comfortable position. Skin care: encourage regular baths to reduce the discomfort associated with dryness of the skin, bruising, decreased sweating, itching, etc. Oral hygiene: inspect the patient's mouth regularly for signs of inflammation and bleeding. Avoid the use of toothbrush and any other material that can injure the mucosa and cause bleeding. Encourage frequent mouthwash. Assessment: monitor and record patients' vital signs at regular intervals. Monitor BP more regularly if patient is hypertensive. Weigh patients at the same time daily. Assesses patients' orientation to time, person, and place. Do a daily physical assessment of all the system to monitor the effects of uremia on it and provide symptomatic care as required. Observation: observe patients' response to treatment or aggravating factor. Monitor vital signs, especially pulse, respiration, and blood pressure. Maintain a fluid intake and output chart to assess its response to vomiting, diarrhea, excessive sweating, etc., and replace fluids as required. Assess patients for dehydration, skin sugar, mucous membrane, pulse, etc. Diet: serve well-nourishing diet as tolerated but preferable a soft diet to ensure easy digestion. Restrict protein intake and adjust using BUN results but increase when patient is on peritoneal dialysis. Provide adequate carbohydrates. Restrict foods containing potassium because it is not effectively excreted in urine. Remove all substances that stimulate nausea. Ensure intake of low-salt diet. Restrict fluid intake to avoid fluid overload but should be in keeping with the volume of the output. A fluid intake of at least 1,000 ml is advocated. Rest and sleep. Encourage patients to rest and sleep to avoid exhaustion from dizziness, vomiting, etc. Cluster nursing activities so that his sleep is not interrupted. Reassure patient to reduce anxiety, increase relaxation, and induce sleep. Investigations. Ensure and assist the patient where necessary in carry out prescribed investigation like BUN, full blood counts, HB abdominal scan, etc. Medications. Give patients is prescribed antihistamines, antiemetics, antihypertensive, anticholinergics, vasodilator, antihistamines, and diuretics. Explain and monitor patient for side effects of drug and provide care if required. Advice or education. Carry out education concerning health care of the skin, hair, nails, and mouth. Infection prevention of falls. Dialysis and transplantation are the main management necessary for the survival of the patient. Complications of ESRD. Hyperkalemia due to decreased excretion, metabolic acidosis, catabolism, and excessive intake, diet, medication, fluid. Pericarditis, pericardial effusion, and pericardial tamponade due to retention of uremic waste products and inadequate dialysis. Hypertension due to sodium and water retention and malfunction of the renin, angiotensin, and aldosterone system. Anemia due to decreased erythropoietin production, decreased red blood cell lifespan, and blood loss during hemodialysis. Bone disease and metastatic calcification. Possible compilations. Anemia, bleeding from the stomach or intestines, bone, joints, and muscle pain, brain dysfunction, confusion, and dementia. Changes in electrolyte level, changes in blood sugar, damages to nerves of the legs and arms, fluid buildup around the lungs, heart and blood vessel complications, congestive heart failure, coronary artery disease, high blood pressure, pericarditis, stroke, hepatitis B, hepatitis C, liver failure, hyperparathyroidism, increased risk of infection, malnutrition, phosphorus levels become too high, potassium level becomes too high, seizures, skin dryness, itching or scratching, leading to skin infection, weakening of the bones, fractures, joint disorders. Dialysis. Definition. Dialysis is the process for removing waste and excess water from the blood, used primarily as an artificial replacement for the lost kidney function in people with renal failure. Dialysis may be used for patients with an acute renal disease or those with ESRD. Indications for dialysis. Urgent referral to a nephrologist for dialysis is indicated when chronic renal insufficiency progress to ESRD as manifested by a creatinine clearance greater than 15 ml per minute and the presence of one or more of the following uremic manifestations: incessant vomiting, encephalopathy, overload of fluid in the lungs that cannot be removed by diuretics, metabolic acidosis, electrolyte abnormalities, especially hyperkalemia, uremic pericarditis. Principles of dialysis. Dialysis works on the principle of the diffusion of solids and ultrafiltration of fluid across a semi-permeable membrane. Diffusion is a property of substances in water. Substances in water tend to move from an area of high concentration to an area of low concentration. Blood flows by one side of a semi-permeable membrane and a dialysate or special dialysis fluid flows by the opposite side. A semi-permeable membrane is a thin layer of material that contains holes of various size or pores. Smaller solids and fluid pass through the membrane, but the membrane blocks the passage of larger substances. For example, red blood cells, large proteins. This replicates the filtrating process that takes place in the kidneys. When the blood enters the kidneys and the larger substances are separated from the smaller ones in the glomerulus. Types of dialysis. There are 3 primary and 2 secondary types of dialysis. Hemodialysis primary, peritoneal dialysis primary, hemofiltration primary, hemodiafiltration secondary, and intestinal dialysis secondary. The 2 main types of dialysis are hemodialysis and peritoneal dialysis, and they remove waste and excess water from the blood in different ways. Hemodialysis. In hemodialysis, the patient's blood is pumped through the blood compartment of a dialyzer, exposing it to a partially permeable membrane. The dialyzer is composed of thousands of tiny synthetic hollow fibers. The fiber wall acts as the semi-permeable membrane. Blood flows through the fibers, dialysis solution flows around the outside of the fibers, and water and waste move between these two solutions. The countercurrent flow of the blood and dilates maximum the concentration gradients of solids between the blood and dialysates, which helps to remove more urea and creatinine from the blood. The concentration of solids, for example, potassium, phosphorus, and urea, are undesirable high in the blood, but low or absent in the dialysis solution, and constant replacement of the dialysate ensures that the concentration of undesired solute is kept low on this side of the membrane. The dialysis solution has levels of minerals like potassium and calcium that are similar to their natural concentration in healthy blood. For another solute, bicarbonate, dialysis solution level is set at a slightly higher level than normal blood. To encourage the dilution of bicarbonate into the blood, to act as a pH buffer to neutralize the metabolic acidosis that is often present in these patients. The levels of these components of dialysate are typically prescribed by a nephrologist according to the needs of the individual patient. The cleansed blood is then returned via the circuit back to the body. All filtration occurs by increasing the hydrostatic pressure across the dialyzer membrane. This usually is done by applying a negative pressure to the dialysate compartment of the dialyzer. This pressure gradient causes water and the soft solute to move from blood to dialysate and allows the removal of several liters of excess fluid during a typical 4-hour treatment. Peritoneal dialysis. In peritoneal dialysis, a sterile solution containing glucose called dialysate is run through a tube into the peritoneal cavity. The peritoneal membrane acts as a partially permeable membrane. Diffusion and osmosis drive waste products and excess fluid through the peritoneum into the dialysate until the dialysate approaches equilibrium with the body fluid. Then the dialysate is drained, discarded, and replaced with fresh dialysate. This exchange is repeated 4 to 5 times per day. Automatic system can run more frequent exchange cycles overnight. Peritoneal dialysis is less efficient than hemodialysis, but because it is carried out for a longer period of time, the net effect in terms of removal of waste products and of salt and water are similar to hemodialysis. Peritoneal dialysis is carried out at home by the patient, often without help. This frees patients from the routine of having to go to a dialysis clinic on a fixed schedule multiple times per week. Peritoneal dialysis can be performed with little to no specialized equipment other than bags of fresh dialysates. Complications: hypotension, cramp, nausea and vomiting, headache. Nursing management of the patient undergoing dialysis. Before, evaluate the patient's understanding of dialysis, explain the procedure, its purpose and implications to the patient and family, and allay their anxiety. Obtain informed consent. Ensure that patient has done his investigations such as serum creatinine, urea and electrolytes levels, hemoglobin estimation, packed cell volume, screening for HIV and hepatitis B, etc. Admit patients into a lazy boy chair or bed. Weigh patients before and after the procedure. Shave the area from the umbilicus to the perineum. Give the patient gown to put on. Check patients' vital signs before and monitor closely throughout the procedure, especially pulse and BP. During, 3 nurses and a doctor are needed to carry out this procedure. The first nurse primes the machine, that is, fixes the blood line on the machine and using normal saline to flush out the chemicals used in preserving the lines and getting the machine set for dialysis. She also sets the parameters such as ultrafiltration volume, heparin rate, and pre-stop. The second nurse sets the trolley and assists the doctor to cannulate the patient. The third nurse acts as the circulating nurse. After the cannulation, the patient is connected to the machine with the aid of the blood lines. The arterial lines carry the blood from the patient to the machine, and the venous line returns blood from the machine to the patient. The procedure takes about 4 to 6 hours. For few new patients, it takes about 2 hours or more as the patient tolerates. Monitor cannulation. Monitor cannulation site for pulling out and patient vital signs closely every quarterly hour during the procedure. Give prescribed IV Mazolone 10 mg through the machine. If patient becomes hypotensive, lower flow rates and give normal saline. If restless and hypoglycemic, give 50% dextrose. In severe anemia, blood is transfused through the arterial line. After, the blood is returned back to the patient at the end of the procedure. Take and record parameters in the dialysis chart, e.g. the UF or ultrafiltration volume, disconnection time, number of hours of dialysis, vital signs after the procedure, etc. Disconnect patients from the machine. Femoral catheters should be removed, bleeding stopped. Dress site with gauze and apply adhesive tape. Clean patient up. Assesses patient's general condition and reassure him and his relations. Wheel patient back to the ward, or if an outpatient, he can go home when he is well rested. Disinfection of the machine. If disinfection is done using clean Cat A and C, while chemical disinfection is done using Dalos. That helps. Patients can take light food before and during dialysis. Patients on regular dialysis of 3 times a week are advised to eat enough protein to keep healthy. Avoid patients to avoid high potassium containing foods because potassium increases the rate of cardiac contractility. Low salt diet for hypertensive patients. Diabetic diet for diabetic patients. Drugs. Administer prescribed monthly erythropoietin. Patients on monthly erythropoietin must take enough iron orally or iron dextran through infusion. Points to note. Do not use the catheters for any reason other than dialysis. Do not take BP or carry out any other procedure over the IV line. Monitor skin integrity around the insertion site. Note that the shunt is warm to touch. Auscultate the palpate for a bruise. Notify the physician immediately if signs of clotting, hemorrhage, or infection occurs. Study section summary. In this study section, you have learnt about the different classes of renal failure, the signs and symptoms of renal failure, management of renal disease, medical, nursing, dialysis. Take 2. Management of renal disease, medical, nursing, dialysis. We've come to the end of study section 1.